All right, so Emmy and I often give talks together, and so you're going to see some similarities in my slides and hers. I think we've, at this point, kind of have our similar template. So it's a total honor to be up here. I'm actually going to be leaving right after this talk. I'm giving a talk tomorrow in New York City with a military doc who's a gun owner who lives in rural Oregon around exactly this issue of breaking down myths around firearm injury prevention and how we can create a path forwards. But today, I've been asked to talk about creating consensus, developing a firearm injury research agenda. I think this talk probably would have been a little better at the end, but I thank the organizers for letting me do it today instead. I apologize. So bear with me. It is a little bit out of context, but I'll try to make it interesting despite the fact that I'm doing it at the end of the first day. My disclosures, like Emmy, I do have research support from NIH for violence prevention research, including as part of the FACS Consortium, which Rebecca and Pat will be talking about later. I'm on the board of directors for the Society for Academic Emergency Medicine, and I'm the chief research officer of AFFIRM. So, consensus. I'm supposed to be talking about creating consensus around firearm injury. Well, the first and biggest question to me is, what does it mean to create consensus, right? Consensus among whom? Among a bunch of public health researchers, among a bunch of physicians, among a bunch of patients, right? The first question is, whose consensus do we care about? And so as I start thinking about where we've achieved consensus around research agendas, I'm going to use as a lens a project that I led within the American College of Emergency Physicians after Sandy Hook. At the time when I led this project, AFFIRM had an incredibly non-public health focused firearm injury prevention policy. We got the policy rewritten, and as part of rewriting the policy, got a mandate from my board of directors to create an agenda for what research could and should look like for clinicians in emergency medicine. And as we started trying to create this consensus agenda, our first step was to say, what's already out there? Now, obviously, all of you, back when NAM was IOM, were part of the IOM 2013 report. I know Steve was one of the leaders of it. And at that time, in 2013, what the consensus was that there were 5 areas where research was needed for firearm injury prevention. The first was research around the characteristics of gun violence. Second, what interventions and strategies need to be taken, but there was a large focus here on policy. Third, gun safety technology. Fourth, video games and other media. And fifth, what are the risk and protective factors for engaging with gun violence? But when you read through this report, it's a very high-level set of recommendations. It's not super relevant for the individual clinician practicing in the trenches on a day-to-day basis. So then we started looking further. Around the same time as the IOM report, a whole bunch of different medical organizations came out with consensus statements around what needed to be done to prevent firearm-related injury and death. The top is a piece that was published in Annals of Internal Medicine, and then on the bottom are kind of smaller society statements, including AMA, which was a big deal for the AMA to come out and call firearm injury a public health problem. All of these calls to action, again, were largely around policy issues and were based on the best available evidence. But when you actually went and looked at what was applicable to clinicians, there's very little. This is a systematic review that I worked on in 2014 and 2015. Rebecca and Pat were part of it, along with 2 of my residents at the time. We found that there were only 53 articles that had been published examining clinician attitudes or practice patterns about firearm injury. Only 7 that examined patient attitudes towards firearm screening. So going off of what Emmy just said, right? What do patients think when we ask them questions? Only 7 articles described it. And there were only 12 articles that assessed patient-level interventions, only 6 of which were RCTs, and those had pretty much stopped when CDC and NIH funding stopped in the late 90s, early 2000s. So our consensus was, well, there's pretty much nothing for us to achieve consensus on. So let's go back to the table and start again. So we got together a group of stakeholders, and here, like with Emmy, we thought it was really important to make sure that those stakeholders were broad. We included not just emergency physicians, but also PhDs. We made sure that we had folks from across the full spectrum of emergency medicine. Emergency medicine has a long and strong root in military history, and so we have a lot of tactical and military folks who are part of our specialty. We made sure that they were represented on our stakeholder committee. And then we started working to try to create what is our consensus agenda for what we need to know as emergency physicians in order to solve the problem of firearm injury in our EDs across the country. We used nominal group technique, which for any of you that have been involved in consensus processes before, and I know Pat and Rebecca will be talking about what we're doing within the FACTS consortium later, is really kind of the standard practice for how to create a consensus agenda. You start with idea generation, kind of allowing anybody to throw out ideas. Then you do round-robin presentations where people have the chance to add on. You have a structured discussion, and then you rank ideas to come up with your final consensus. In terms of the first process, where we're starting to get the ideas together, I know that earlier the Haddon matrix was mentioned, which is like the cornerstone of injury prevention, right? So we decided that we were going to use the Haddon matrix, the pre-event, event, and post-event, along with the kind of 4 typical factors, and then using a slightly more complex model that was put forward. I think this was Carol Runyon, actually, that put this forward, talking about kind of more aspects to the Haddon matrix as well. And like many of us are doing here, we made a consensus decision among our stakeholders that we'd talk about 5 types of firearm injury, right? And at the point when we were doing this, there was still a lot of debate about how to structure the discussion. We felt that suicide, intimate partner violence, peer non-partner violence, mass shootings or mass violence, and then unintentional or accidental injury were the 5 categories we wanted to focus on. As Emmy presented earlier, obviously mass violence and unintentional injuries are the minority, right? But they're still important from a psychological perspective for our communities. So then we went through to that generation, discussion, and iterative refinement. We did the lit review of the various kind of subgroups for the various types of injury, came up with 61 questions. Then in our round-robin process, expanded that dramatically up to 222 potential research questions, right? We're like, oh my God, we could write an entire book. Then we refined them down. We figured out that a lot of questions were really similar between the groups, which is something, of course, that we've been hearing here over and over again today, right? Each of these different discussions, there's some similar themes that keep coming up. So we were able to separate all of those out and then to refine further, to combine, and ended up with 63 questions that we then put out for voting. Interestingly, in our voting process, we had an internal vote that got rid of 4 questions, and we kind of used predetermined criteria, like they had to be voted, they had to be 1 standard deviation below, or voted not important by anybody. Then we presented it to external stakeholders. So again, this idea of if you're going to create consensus, you don't want it to just be consensus among yourselves, right? If it's just like my group of friends who all say something is important, that doesn't have any bearing on greater society. So we then sent it out. So we sent it out to the whole tactical EMS section of AFFIRM. And anyone who's ever been to an emergency medicine meeting will tell you that some of those guys are like not going to love anything firearm injury related. But they actually voted that these questions were really important, which helped to then legitimize it in the eye of my board of directors. So we finally ended up with 59 questions that we put together. We did map whether or not those questions were already in the IOM report, recognizing that all of you guys had already done some really great and important work. And we found that 16 of our 59 research priorities mapped to IOM. We also highlighted questions that were directly relevant to clinical practice versus those that weren't. Some of the questions, like in the IOM report, were like these much higher level things around, what is it that we should do within our greater communities to create equality and address social determinants of health. But a lot of them were immediately clinically relevant. And I won't go through them in detail. I did put the reference into your packet, but we had them divided by cross-cutting, by suicide-related, by intimate partner violence-related, with, I think the arrows here are the ones that were in the IOM report. Peer violence, unintentional, and mass violence. And I think that these questions will hopefully be useful to you guys at Kaiser, because I think that they are, you can substitute what is the role of acute ED care in preventing the development of post-traumatic stress syndrome after a firearm injury. Well, substitute any staff, right? Like that doesn't have to be ED staff. And as we've gone and kind of talked about this consensus-driven agenda outside of our own specialty, we have found that it actually resonates deeply with folks in other specialties as well. Around the same time that we were doing this, Emmy and Garen Wintemute and I wrote a paper called Yes You Can, Physicians, Patients, and Firearms, where we laid out what we thought that the best quality of the evidence was for what physicians should be doing now in the clinical space. And in here, we talk about a lot of what has been talked about already today, but about there being 3 major conditions where we should be considering screening and intervention, those being an acute risk for violence to self or others, individual level risk factors for violence, and then the third being a member of a demographic group at high risk. Middle-aged and older white men because of suicide, younger African American men, children, and adolescents. And in the paper, we kind of went through what we thought best practice was. We then have worked kind of based off of that consensus agenda to try to develop those resources for providers. So an example there is the What You Can Do website, which is hosted by Garen Wintemute out at UC Davis. There's a series of handouts that can be given to patients and providers. There's a project that Chris and I and a few others in the audience worked on with the Massachusetts Attorney General's office. Emmy talked about the importance of that local legal landscape. And so we worked with the Mass AG to say, okay, here are our consensus recommendations. Here's expert advice on what physicians should be talking about with patients, but what's legal for them to tell patients to do, right? If I have a domestic violence patient whose partner has a gun, can I tell her legally that she can take the gun to a pawn shop? In many states, that's okay. You don't have to do a background check. And you don't want to steal the gun, right? Because that's illegal. But like, what's the right thing? When am I allowed to disclose? When am I required to disclose? So that was the project with the Mass AG. And then, I don't know if I heard that Andrea Garcia is here, but we're working with we're working with the AMA right now. We actually have a CME module that's about to come out that really goes through this process in detail, and that may be useful to you guys as you're thinking about kind of next steps for the providers within Kaiser. There's also, of course, a lot of ongoing research that's trying to address some of these questions in a roundabout way. This is IDOVE, which is one of my personal research studies where we're doing a brief intervention and then doing texting. We're in the middle of the R01 to kind of look at efficacy of this, but my initial results were promising. There's the work of PAT that I know that Rebecca will be talking about later with firearm decision, with similar apps for patients who are at risk of firearm injury. Obviously, Emmy's stuff as well. And the thing I was raising my hand about before that I didn't get to talk about was the use of technology, right? And the importance of us thinking about innovative ways to get over these barriers, to get over these dissemination, these classic humps that make dissemination stop, right? So how can we use technology to facilitate these patient-provider conversations? There's the FACS work group, which Rebecca will talk about in much more detail, where we're trying to look in detail at these issues for adolescents. And I'll highlight here that I'm leading the secondary prevention and long-term health work group talking about the mental health stuff. But at the end of the day, despite all of this stuff that has come out of this consensus research agenda that we created 3 years ago, the trouble is that there's still virtually no funding, right? So from 2004 to 2015, this is an article published in JAMA, the funding rate for gun violence research was only 1.6% of what would be predicted based on the mortality burden compared to sepsis, which all of us have sepsis protocols. Meanwhile, the fatality rate for gunshots is going up. Gunshot wounds are the only type of traumatic injury with increasing case fatality rates. And although we have these wonderful research agendas, they're just an agenda without funding and action. And many of us have found ways around the lack of funding, right, to try to do our best to get answers. But without a concerted effort from our community and those that we partner with, it's not going to move forwards. At the end of the day, I want us to remember that the reason why we are all doing this is not for our own careers and not because we want our health systems to look awesome and not because we're searching for NIH funding, but it's because of our communities and our patients and our friends and family members. This was a Twitter thread that I was part of after Parkland, where we had around 300 physicians from around the country who shared stories about patients and family members and friends who'd been hurt by gun violence. Because at the end of the day, this is about reducing the human toll. And with consensus, with a broad consensus that includes not just those of us in the room and not just those of you on the webinar, but also Americans from across the political spectrum and from across every locality in America, I think that we can make progress as a group. So that's it. Thank you. I welcome questions.
Thank you.